Okay, schizophrenia. This section was on the whole quite good, I have to say. Yeah, things are looking up, guys. Question 8, briefly outline a negative symptom. So the issues here were that some people accidentally picked positive ones. Understandable in a high stress situation, but you don't want to drop 2 marks on something that is quite straightforward. So just make sure you go over that again. For negative, the trick is, if the key term has an A in front of it, it's generally a negative symptom. So alogia, avolition, because it means that you're lacking something. That's how that kind of terminology works. Lots of you described alogia, affect, and avolition without naming the key word. Just be careful with that. I gave you marks this time as long as description was full enough, but another examiner might not. Remember tolerance, 1 mark. I can decide actually that's not enough and it's still within tolerance. And even if you went for a remark, the chief examiner has to let that stand. So say enough that they have no doubt but to give you those 2 marks. Fill the 4 lines. I'm not entirely sure 4 lines is necessary in a question like that, but yeah, the key word plus a description is perfect, or an example is perfect for those questions. Number 9, evaluate antipsychotics. This was much better than it has been, so you are really getting to the point now where you look at the key word and you're not generally wasting time. If you are one of those people that unfortunately wrote me out an 8 marker on outline and evaluate antipsychotics, then bless you. I can't give you full marks because you haven't used the correct AOs, and the likelihood is that you haven't given me enough AO3 either. You have to, in order to get to top marks, you have to show that you read the command word correctly. So evaluate for an 8 mark means just 4 detailed AO3 points about antipsychotics. Lots of you wrote loads about side effects, but in different places. So you'd do the side effects of each of the 3 drugs in different parts of the essay. That's not good. Just make side effects 1, okay? Don't separate out, this one gives me a blood disorder, this one gives me an MS, and this one gives me muscle problems or whatever. No. Side effects is 1 AO3 point, okay? So be careful with that. Loads of you remembered Meltzer, Thornley, really, really good. I mean, I would have struggled to remember the names of those. Really very, very good. And lots of you were able to also talk about how studies have shown that if you combine CBT, is it Jawahar? If you combine CBT with antipsychotics, it elevates the success rate and the chances of relapse diminishing. So that was really good. The one thing I would maybe be really careful of, and I might actually change my PowerPoints for next year, is I might remove the idea of the other dopamine hypothesis because you're not really using it effectively. So the essay is on evaluate antipsychotics. So antipsychotics are the drugs which block dopamine, yeah? So what you are saying, if you are using the alternative theory, is you're saying, well, actually, antipsychotics don't work for everybody because another theory is that it's lack of dopamine that is causing the schizophrenia, and therefore if it's lack of dopamine, then this treatment isn't going to work because it's just going to stop dopamine and lower it even further. So these patients would need drugs which elevate dopamine, which are in the form currently of amphetamines, but research shows they don't work either. So that's okay if you say it like that, but if you just suddenly start talking about, actually amphetamines don't work for everybody and they increase symptoms, well, that doesn't make any sense because the essay is on antipsychotics. So you have to explain why you're raising the point of amphetamines first. I hope that makes sense. I think what I'm going to do is remove that from the PowerPoint. And if you are under any illusion you just think, what, take it out, don't talk about it again. Talk about how antipsychotics are much better for the economy because they're cheaper and they really do reduce positive symptoms, particularly, and some can reduce negative symptoms too. So substitute that alternative dopamine hypothesis for psychology and the economy. That's fine. Yeah, on the whole, that was a really good 8 marker, I have to say. Very, very good. Okay, and then moving on. Number 10, the family dysfunction AO1 question, really good. Most of you told me about schizophrenogenic mother and double bind. Some of you brought in a third one as well, but on the whole, really, really well answered. I would just do 2 in a little bit of detail, like most of you did. Very, very good. Explain how symptom overlap might lead to problems. The best answers were the ones where you said, you know, things like psychosis, evidence of psychosis, and some of the positive symptoms also linked to bipolar, which is often the alternative diagnosis when symptoms present in this overlapping way. But you've got to be sure you've made the right diagnosis, because that affects the treatment, and the treatments for bipolar and schizophrenia are different. So you don't want to be diagnosing the wrong disorder and therefore administering the wrong treatment. Those of you that brought in depression as the symptom overlap, that's not really right, because you can have both. You can't have schizophrenia and bipolar, because they're 2 psychotic disorders that are treated very differently. But you can have schizophrenia and depression, because you learnt about that in comorbidity. They exist together, the disorders exist together. Yeah, that's a different thing. So comorbidity is when you have 2 or more disorders at the same time. So I can have schizophrenia and depression, but symptom overlap isn't having 2 or more disorders at the same time. It's having symptoms which overlap with each other, and you need to make a choice as to a diagnosis. Be really careful with that. Okay, they are different concepts. Number 12, outline how CBT is used to treat schizophrenia. On the whole, this was okay, but lots of you didn't answer the how. So you just said what CBT does. So it aims to change thought processes and rationalise thoughts. You didn't tell me the how. So by stuff like using diagrams to show where the delusions are coming from, by, you know, relaxation techniques and distraction techniques which increase social behaviours. There's so many different things you could say there, but you missed out the how. How means steps, techniques, what they're doing. And lots of you missed out the limitation, so you just didn't kind of process the whole question. It was 2 marks on how and 2 marks on a limitation. If you are going to say stuff like you have to be really motivated to access CBT, yeah, that'll get you a mark. But what we're talking about, schizophrenic patients here, are they motivated? Lots of them have avolition so bad that they lack that motivation. So talk about schizophrenic patients rather than general patients. Or you have to build a trusting alliance with your therapist. Is that possible with all schizophrenic patients? No, because they have delusions of persecution and they think their therapist is trying to hurt them. So yeah, be careful to make sure you're in the schizophrenia section, you are talking about schizophrenic patients the whole time, not just general people, yeah? And then finally, number 13, I thought long and hard about whether to put this question in, because I thought it was really, really difficult. And you needed to pick your own AO3, because I didn't dictate it to you on the PowerPoint. Lots of you managed it. So you had to outline, evaluate 1 study in relation to the validity of diagnosis. You had 2 choices, basically. You had Chenio or Rosenhan on being sane in insane places. So Chenio is the one where they had 2 psychiatrists use the DSM and the ICD to diagnose 100 patients, and there were vastly different results. Lots of you forgot the results. Try and remember them. That study is really important. And lots of you weren't able to tell me any AO3. So you gave me a really good detailed description of results, but then you didn't comment on what this means. The best AO3 that you could have come up with off the top of your head is what we kept talking about in class, is what the hell does this mean for society? If this study is an illustration of what is happening in real life, then we are screwed. Don't write that in those words, but 100 patients being diagnosed so vastly differently. In one case, it was something like 20 out, yeah? What does that mean for what's happening in the real world? Are there hundreds of people in mental health units with the wrong diagnosis, having the wrong treatment? What's going on? Why are these diagnoses so drastically out? So what your AO3 point should have been is what this means for the real world, or pointing out that this has to change, that somebody needs to recognise the issues that are being presented and the challenges presented in the validity and diagnosis of this disorder and do something about it. These two diagnostic tools need to be aligned, because this cannot go on. You could have come up with that yourself. Lots of you came up with another good idea, which is the fact that 2 psychiatrists isn't enough to generalise these findings to the world, because we have hundreds of thousands of psychologists across the world that may have made better use of the diagnostic criteria or been, you know, more thorough. Fine, absolutely fine. Or the fact that 100 participants isn't necessarily enough. Like, sometimes you said enough about that AO3 point, but there are going to be times where I cannot predict what AO3 they are going to want, and you are going to need to use your knowledge to come up with something. Implications and what this means for us is always a really, really good thing. The other one, the on being sane in insane places, one where you illustrated that it was really hard for the participants to get out on their own, and some were to kind of prove their sanity, and some were in hospital for 52 days, even though there was nothing wrong with them. And then you use the AO3 point of actually times have changed and the diagnostic criteria are different now from I think that was 1973, that study. And you're right, we're on the DSM-5, aren't we? And the ICD-10, I think we're actually just had published the 11 and the 6 even. So the tools have changed, and some of you pointed that out. That was such effective AO3, like temporal validity. We've moved forward, you know, we're 50 years on. Hopefully there aren't people in psychiatric units with an incorrect diagnosis of schizophrenia when they are actually sane. Hopefully, because that study absolutely shocked psychiatry, and it definitely did make things better. You know, that cannot be disputed. All psychologists would agree that that would not happen again, to that, you know, that you would actually have nothing wrong with you and get sectioned. That just wouldn't happen now. No way. Very good. Okay, so that's schizophrenia.